good morning and good afternoon to all of you. Thank you so much for joining our final LAN session with our learnings from the field. As a reminder, PATH Leadership LAN tools and resources can be found on our website. Just visit healthinsight.org/PATH and click on the Staff Development and Training page. I'm your facilitator, Francesca Flores. You can chat to me privately by selecting my name from the To drop-down list in chat, or you can chat to the whole group by selecting everyone on the chat list. This is also the best way to give us any questions you have for our speakers to answer at the end of their presentations. Thank you all again for attending our November Learning in Action Network for 2019. This LAN will feature quality improvement implementation experts who will share their learnings from you and how those lessons learned fit into an implementation framework. We'll hear from Becky Blystone, Brianna Goss, Jane Brock, and we'll do some Q&A at the end of the session for any questions you might have on the material that they've presented. Right now, I'd like to introduce Demetria Cianci-Chapman, the Director of the Partnership to Advance Tribal Health.
Hello, everyone, and welcome to our final official LAN session. We do have one more open hour session to provide some technical expertise and coaching on tools developed for the AIM-3 sub-aims and data collection. I think that's my only announcement. So Becky, if you want to take over.
Yeah, sure. And thank you, Demetrius. I can actually go ahead and share my screen now, Francesca, and we can go ahead and get started on our presentation for the day. So give me one moment.
Oh, Becky, you know, I didn't realize that was my time for updates. I do have a couple.
Oh, okay, wonderful. Go ahead, Demetrius.
So the PATH team met in Minneapolis the last full week in October to strategize how best to use the remaining time and resources of the project. And small-scale strategic plans were developed for the next quarter. And Friday will be my last day with the project because I'm moving on to a local public health role. The project is going to be operationally managed by Assistant Director Mary Altenberg, and outward facing activities will be handled by the Comagine, New Mexico QIO Director, Ann Timmons. And now I really am finished.
Great, thank you, Demetrius. I will go ahead and get started. Thank you for those updates. Today, for our final LAN session with all of you, the QuIN-NCC, the Quality Innovation Network National Coordinating Center, will actually be sharing out our learnings from the field. So what we've heard and learned from all of you over the past couple of years of participating in PATH, as well as several site visits that we conducted. My name is Becky Blystone. I had the pleasure of meeting quite a few of you over the summer. I am the program specialist and task lead for this work at the QuIN-NCC. Today, we will be joined by Dr. Jane Brock and Brianna Goss, both of our implementation researchers from the QuIN-NCC. I will do a brief background for those of you who might not be as familiar with the QuIN-NCC and our role in PATH before we move into what we've heard and learned from all of you, and a little bit about the implementation framework that we are using to help us better understand the innovative strategies and promising practices that are going on in the service units that will help us share those learnings with other facilities. So a little bit about the QuIN-NCC. Some of this might be repeat for those of you, so thank you for being patient. We are the national level partner of PATH. On the right-hand side of your screen, you will see the Quality Innovation Network Quality Improvement Organization, or the QIO program, that provides technical assistance and support for healthcare organizations all across the country. And PATH brings that specialized assistance to the left-hand side of your screen, the PATH map. As the National Coordinating Center, we provide background support for the Quinn QIOs all across the nation, and that specialized support for PATH as well. I included a few of our Quinn and CC tasks below. What we are doing for the PATH program specifically is that collection of promising practices and innovations. So what we will be sharing today is a little bit more specifically around this work. Our focus was the successful activities and support structures, being used at the service units. Our task was to collect those promising practices, strategies, tools, things like that, to collate them here and then share them back out with other service units. Our goal is to develop a change package from all of this information for implementation-ready techniques and things like that, so that it leads to systems level improvement for healthcare facilities. So as I mentioned, part of this promising practices collection, we conducted 6 site visits this summer to 4 different areas. We have them highlighted on the screen. I would like to take a minute and thank all of those facilities that said yes to us coming in. We know that it was above and beyond your current work for the facility and what you do for PATH. And we are just so grateful that all of you decided to open your doors to us, share your stories, share both your obstacles and issues and how you solved them. We're very grateful for all those learnings. We visited the Crow Service Unit, Standing Rock Service Unit, Red Lake Service Unit, Cass Lake Service Unit, and then down south to the Northern Navajo Medical Center and Chinle Comprehensive Healthcare Center. Thank you to all of you, and I hope you're on the phone today because you are more than welcome to say, yes, you guys got it right, or no, maybe I would tweak what you all learned. We are here to hear your feedback. So I will hand it over to Brianna Gass of the Quinn NCC. As I said, we've collected all those promising practices, and Brianna will help frame how we are thinking about those practices into an implementation framework. And then she will hand it over to Jane Brock, who will situate all of those promising practices that we've heard about into an implementation strategy. So,
thank you, Becky. Hi, everyone. As Becky mentioned, we went on a number of site visits, 6 of them to be exact. And during this time, we learned about a wide variety of programs and improvements that each of the facilities we visited were trying to make. We also understand that each hospital or facility faces a different set of challenges in doing the work. They serve different populations. They have very different geographies. They have different sizes, so many differences. So you may be asking yourself, how is it that you can possibly visit 6 places and make sense of what you've learned? And that's really the purpose of using an implementation framework, because what it does is it says, yes, all of these contextual factors are in fact very important in the ability to make changes and make improvements. And so an implementation framework helps us by acknowledging that context is variable, that it is important, but most importantly, that contextual factors can actually be measured. So this is some of what we attempted to do in understanding what was going on at each of these sites. So an implementation framework also helps us to meaningfully assess the factors that are most likely to impact implementation. So what that means is if we want to make a change, what is that change up against? And when I say against, I use that term loosely because there are also factors in any environment that may in fact help facilitate something to be put in place or something to be changed. So what the implementation framework helps us with is to understand what those factors are and concretely identify what facilitators can be leveraged to help move a change forward, as well as identify potential challenges that we can help mitigate before we actually run into them. So in addition to that, it helps us understand a little better what context we're dealing with and even better match the interventions that we put in place in order to make sure that what we do makes sense in a particular setting. And finally, we hope that understanding the context and that implementation takes place in will help us understand what the factors are that will help enable improvement to take place in all of these different environments. Next slide. So we really found that there were two major factors that serve kind of as a foundation for allowing promising practices to be put in place. The first of those I'm going to call implementation climate. And what this really means is that this is a setting's capacity to make change. So is the environment conducive to change, or are there factors in the environment that make it very difficult to put any change in place, no matter what the goal of that change is, or how much better it may actually be for everybody once it's done. So we found that a setting's capacity for change is very important in being able to successfully put interventions in place in any of these settings. And what this means is the setting is receptive to ideas on how to make improvements. It's receptive to people bringing ideas forth that are innovative, and that there's also an expectation in the setting that these ideas for making improvements will be supported and encouraged. So to briefly define implementation climate, it's the recognition among those in the environment that something needs to change. It's an understanding that the change is going to be not only produce a good outcome for the organization, but that it's going to be a good fit in terms of how the organization already operates. This could include things related to the values or culture or norms of the organization, and also the available resources the organization has in place to dedicate to making the change, as well as existing practices, processes, and workflows that people undergo every day. So a better fit intervention is going to fit more nicely into existing workflows than upend everything people already do. The organization, as I mentioned, also encourages and supports change, and this can sometimes look like come in the form of incentives. So people are rewarded for proposing various changes in the organization and coming up with ideas and taking the lead on making those changes happen. The goals of the change are very clear to everyone in the organization, and it's also clear that movement toward that change is being monitored in the form of data collection, looking at various metrics, understanding the impact that this is having in the interim as well to those working in the organization, as well as the population that is being served. And finally, overall, the organization encourages learning and growth. So they are willing to accept that sometimes people make mistakes, sometimes a change doesn't work out the way everything was planned, but that the organization really looks at this as a learning experience, and people are still encouraged to make changes because of a fail-forward culture. Next slide. The other major component that serves as a foundation for promising practices is readiness for implementation. These essentially are tangible indicators of the organization's commitment to making a change, and this really shows up in the form of support as well. So it could be resource support, such as staffing, putting forth financial resources that enable a change to take place. So it may cost the organization something, but that's understood that that'll be maybe a benefit in the long term, and it's a worthwhile cost. People are given time to adapt to changes that they need to make in the organization, and that staff resources are also in place in order for people to effectively make the change. This usually, I'd say more often than not, involves a commitment that is visible from leadership in the organization, that they are on board with making a change and they have put their resources or money where their mouth is, so to speak, in that they're actually willing to dedicate resources that are necessary to make the change to it. And finally, access to information. So this is that people in the organization who operate on a day-to-day level have access to information that helps them understand that the change is bringing forth positive results, and that they are offered training and support for the changes that they're going to make in order to put an intervention in place. Next slide. And so you may be asking yourself, what exactly is the difference between an implementation climate and readiness for implementation? And I'm just going to say that for the purposes of our conversation today, that's okay. While in an implementation framework, these are defined fairly differently, there is a ton of overlap between these two components. And the important thing to understand is that neither of these items is sufficient on its own to create change effectively. Building up a implementation climate can help make things more possible to be in a position where you are ready for implementation, and vice versa. So I just included this slide here to kind of show that there is a very interwoven relationship between both of these things and that they feed into each other, but they are equally important in being able to successfully implement interventions. And Jane is going to go ahead and share some examples of what we've learned on these site visits, so I will turn it over to you.
Thank you, Brianna, and thanks everybody for calling into this talk. We learned so much from you all allowing us to spend a huge amount of time, and I'm sure it was considerably inconvenient to some of you who participated in these site visits, but we just learned a ton, and we're really very, very appreciative. So next slide. Yeah, so this is kind of the way I think of these site visits. I think when I know my own self, I was prepared to see a whole bunch of really outstanding programs and people doing great things and impacting, you know, the lives of the people they served. But what I didn't expect was really to see what I'm now thinking of as some really best-in-class implementation infrastructure. And we did not go forward really actually looking for this, and it was striking the degree to which we found it. The reason that Brianna and I are focusing on this notion of implementation climate and, you know, readiness for implementation or the resources to do it is because we just know from site visits and from, I don't know, years and years in quality improvement that facilities always struggle with these things. And particularly you hear a lot, I've never been on a site visit yet, where people did not talk about sort of resource constraints kind of getting in the way of achieving their priority goals. But I think we just saw so many examples of true commitment to an implementation climate that in a sense created resources, and resources that were deployed so creatively that it's really this striking sort of implementation ready infrastructure that we just saw many examples of. So we're going to talk about strategies to get there, but I just want to start by acknowledging that there's some remarkable work going on in these facilities. So here's why we got interested in looking at this from the parameters of you know, basic implementation infrastructure. So, you know, for all the years in quality improvement, we think of, well, there's characteristics of this organization, and they do a process in order to make a change. But you know, the reality is when you start to introduce change, actually, even if you're not introducing a specific change, these three things all change each other. So the very undertaking of improving not only leads to huge modification and ongoing modification in processes, it changes the organization, it changes the character and the context of the organization, which then changes the approach to the change being made. I mean, these three things go forward iteratively and they all change each other. So this static notion of, okay, well, here's our organization, here's the process we're going to use in order to make this change, is really a almost minute-to-minute snapshot. Which is why we've really started looking at the deeper parameters of the implementation infrastructure that allows these things to change iteratively in a productive way. So, all right. In terms of implementation climate, the role of the C-suite is extremely important. And I think we saw very striking examples of humble servant leadership that was visibly displayed all the time, that was reinforced by comments that the staff made. We observed it directly, and we heard about it from committed and passionate people who work in the facilities that we visited. So I think this can't be overstated, the visible commitment to servant leadership from the very top within these facilities. So it certainly promotes a safe environment for experimenting and for failing, as Brianna said, for failing forward. Humble leaders acknowledge that they're figuring out as they go along and that they may not always get it right. Humble leaders are visibly accountable. Very present, are not creating change in a boardroom, are actually leading change in every way, are doing the things that need change, and that they are committed to expressing the need for and observably valuing the contributions of others. These are things that really, in a sense, create resources from staff, in that when staff sees commitment that's going to endure at the very top, then you know, people join up basically and feel good about joining up. So in terms of how we saw this actually deployed, oh, next slide, sorry. How we saw this deployed, I think just culture has been an enormously beneficial strategy for across, I think it's probably across IHS, but we certainly saw it in many iterations in most of the places we went. So there were various ways of being committed to just culture. There are a number of facilities that are really all in. So we saw leadership teams that were not only spoke in terms of just culture, but were actually carrying around the tools for just culture to guide, you know, interviews and that sort of thing. The most frequent application of just culture was tying just culture to increased WEPSIDENT reporting, and certainly there's an obvious connection between those things. So in terms of promising practices, we saw facilities in which the tools and resources were posted everywhere. People were, like I say, carrying around interview guides in every conversation. It led to a standard language for conducting these meetings. There were facilities in which WEPSIDENT reporting and these types of things reported were publicly posted in staff areas, so that all staff could see that if they you know, kind of saw something and you know, ramped it up, that it was being acknowledged. There were a number of ways of also rewarding people for posting into WEPSIDENT and or for identifying near misses. We think this has been a really powerful change force. In terms of leadership accountability, we also saw striking examples. A lot of this had to do with a very open participation of leaders and of, you know, displaying progress everywhere. Strategic plans, specific activities, metrics. There are some facilities that will openly post metrics assigned to individuals in open staff areas. So when during an improvement initiative or a change initiative, we observed places where there were open postings of basically people's to-do lists with names, due dates, and that included senior leadership, that nobody was not included in this sort of public accountability. There were places where in staff areas, and I don't think we observed this actually in open public areas, but where like the CEO's to-do list is right there, and that when things are accomplished, a check mark is placed by that person's name and that activity having been completed. So we also observed CEOs who established what they thought were their key priorities and led through examples. So we went to a facility in which there was absolute accountability for responsiveness. Expectations were set around response times, internal response times and external response times. And that included all of the C-suite, which held the same expectations. They very much were tracking time to resolve patient complaints as well. And this same CEO is doing post-closure phone debriefings with patients. So if a patient registered a complaint and that complaint was resolved in the way that it should be resolved, the CEO was doing sort of convenient sample of follow-up calls to patients and their families to tell them what the resolution was and to get their feedback on that resolution. So we felt like that was a really powerful strategy. Next slide. So in terms of valuing the input of others, I think Just Culture does a huge amount of that, but we also saw an innovative example in one of the places that we visited, where they made an intentional a decision to mine what is already going on. So I think when it comes to change initiatives or improvement initiatives, or really any kind of change, there's sometimes staff fatigue around, oh my gosh, what's the improvement plan du jour, and it kind of drives cynicism. Well, in one unit that we went to, there was acknowledgement from leadership that, really, why should we talk about just new change? Why don't we talk about the changes people are already testing? Like, let's just mine what's going on right now in terms of workarounds, because probably they have good reasons for having workarounds, and the very best ones, we should just, maybe our role should be to make it possible for everyone to fully and openly engage in promising workarounds. So I called it the science fair. The service unit did not call it the science fair, but they invited people to come and present their favorite, workaround, or their favorite, sort of change thing that they were doing in their own work. They could present posters or just, bring in sheets of paper. Here's what I'm trying to do, and here's why. They invited everybody to come and see this, what people were trying to do in the way of change. They also had their external advisory board members come to this event and identified a number of things that could be fairly easily fixed and or promising change initiatives to spend their effort working on and making them sort of institution-wide and accessible ways of doing new work. So readiness to resource allocation, as I said before, resources are always a struggle, but we saw so much creative and effective and efficient use for increasing resources available for important initiatives. So we certainly saw a number of folks thinking very creatively about how to improve access to information and training for staff. Certainly, Just Culture is a way of improving your resources through really engaging your entire staff and making comments without risking anything. Certainly, most facilities are doing intentional training around Just Culture. A number of facilities are also looking at training in trauma-informed care. Team Steps has been a very successful method for sort of training across staff-wide. We saw folks using tools for and audits and sort of available to sort of self-auditing tools, and training folks in the use of them and the expectation that you will self-audit, your department with some frequency. And then certainly a number of tools for quality improvement have been made available, and many facilities acknowledge the role of PATH in helping them access the kind of training and tools that were helpful to them. We saw a number of really brilliant examples of staff empowerment as a resource. I think that this is the kind of thing you hear about a lot. Oh yeah, we empower our staff, and that makes everything better. But we saw really very intentional mechanisms. So folks who are identifying and tabulating staff skills sort of formally, and incorporating those skills into intentional succession planning. So I think there's a lot of knowledge, certainly within the business environment, that people who do not perceive a career path are less dedicated, and the folks that you want to keep sometimes, go and look elsewhere. So we have folks that are really intentionally sort of making visible these staff skill sets and sort of succession planning as a method for engaging staff in, dedication and acknowledgement of their work. Certainly creating expectations and opportunities for participation in quality improvement projects was a very powerful staff resource. We heard a number of places in which participation in quality improvement is just a standard expectation, and it applies to everybody, including the C-suite. So there were some very creative ways of making this real. There was a facility we visited that had identified a clinical coach role, which is identifying somebody within a unit that has interest in quality improvements and the skills for leading quality improvement within that unit and putting them into this clinical coach role for a year at a time, in which they help facilitate data collection and data aggregation and making sense of actual day-to-day operations and outcomes data into improvement projects for that unit, so that you're not asking really busy, say, nursing staff to do additional data collection at the end of their shift. We saw some very comprehensive quality improvement training infrastructure that is being very effective at engaging folks across service units and setting parameters for success in collecting and displaying the data. So next slide. There is a service unit that we visited in which staff time is intentionally protected for quality improvement. So this is something as longtime quality improvers that we hear all the time, and we actually experience in our own work as well, that there are many, many things that you have ideas about and that you would like to help participate in, but the reality is you're already, drowning in work. And so there are service units in which the intention is that everyone participate in quality improvement that actually protects staff time for that. Not only is it expected, the time is given to you in which it is expected that you will develop and implement your very own quality improvement project. So staff skills in this facility are very intentionally supported through a mentorship program and very targeted training, including training in basic data analytics and data display techniques. Staff there are very, very committed to quality improvement, and it really was kind of, it was great as a quality improvement nerd to hear people casually talking about, well, what's your improvement project? Well, I'm looking at, such and such. It's like being on a sort of a graduate school campus. It's really a very pervasive part of the service unit. We also got a huge education in business stability, and we are thinking now that business stability should be a large section, which probably we're just getting started on in terms of a change package. So, we came in as a bunch of quality improvement folks and got a serious education in business and financial stability. So I would say that most service units are really targeting and tightening up their billing processes. We saw a number of best practices on this. Certainly, tight management of third-party billing is absolutely a crucial strategy. We saw a number of ways of approaching this. There are service units that are putting benefits managers at check-in to their service unit to assist with Medicare and Medicaid enrollment. And we heard a lot about the importance of a relationship with the local, your state's Medicaid agency. So there are examples of people who have very specific waivers that help them maintain realistic and sustainable reimbursement rates and have participated in direct negotiations with their state Medicaid agencies in order to ensure that the sort of special contextual challenges of an IHS service unit are fully addressed, and the compensation through Medicaid is built into that. We saw lots of use of the IHS informational posters and other materials widely displayed and acknowledged as helpful to really get the sort of proper recruitment and engagement of patients and the importance of these processes. So I think there's a lot of successful strategies for ensuring that third-party billing is sort of fully accessed. We saw examples, several examples of very insightful analyses of the purchase referred care processes and payments that have led to very specific adaptations of services and programs available. So certainly we believe that the EMS protocols and relationships are absolutely crucial. We saw examples of joint training in this, but certainly an assessment of purchase referred care and the outcomes of that with regard to EMS services. We saw folks that did a lot of analyses to understand the full impacts of purchasing expensive new equipment such as CT scanners, and as a guide to sort of development of on-site services, the needs, the risks and benefits of on-site services like dialysis bays. Certainly, the PRC processes and analysis of those also have guided a lot of patient and tribal outreach about service capabilities in that, you know, there's this, I think, true everywhere, that the integration between tribally run aspects of the health delivery system and the service units is a really crucial interface. We saw a number of examples of folks really integrating the public health nurses. And so this is something maybe just we all, as folks who are often dealing with medical service facilities that do not really have a public health component, we're very fascinated by mechanisms for fully integrating the support of public health nurses into service units' emerging priorities. There are many different ways that service units are approaching this, from everything from, you know, having a relationship with the public health nurses to fully integrating the public health staff within the service unit in terms of like even co-housing them. Excellent relationships with tribal leadership is a very important part of business stability to our understanding, and we saw a number of folks who were intentionally constructing how that relationship would go forward and how tribal functions and service unit functions would be integrated at the leadership level. So here's an example of the proper deployment of these, or the sort of ideal, what ideal deployment of these strategies. So hepatitis C screening and treatment is of interest, I think, is a huge priority everywhere we went. But we saw an example where the before situation where the patients were being screened by the service unit and sent out for evaluation and treatment, but they were returned without beginning treatment because it was too early in the course of the disease to meet the payer guidelines for care under other programs. These folks were frequently lost to follow-up, plus, you know, what a demoralizing message. You're not sick enough to have your treatment covered. So there's a service unit that has gone about very systematically removing these barriers to care. So staff were given the time and bandwidth to explore solutions. They identified a pharmacist with robust experience and expertise. This pharmacist was given staff privileges to recommend treatment plans and write prescriptions and certainly modify in accordance with clinicians, and participating in the ECHO system in order to present cases to receive guidance for treatment planning. This program has been enormously successful in terms of, next slide, sorry. In terms of identifying patients and coordinating their care. The access for treatment funding it's been a huge part of this by having a single dedicated lead, and that lead being a pharmacist, in terms of identifying and gaining facility with the different documentation for different payer sources, including getting patient assistance through the drug manufacturer. Not only does this service unit feel that it is a replicable process, they offered to teach others on how to do this. We have the results. We're getting short on time, aren't we? Okay. So their results are very striking. They have 70 hepatitis B patients have been identified through this new process. 7 are considered cured. 9 have completed treatment. 7 are on current treatment as of the time we visited them. And 4 are in the process of having their treatment plans established. They're working through a backlog. They have 50 patients on the waiting list now for medication funding, and they are working through the process. But this has been an enormously successful program, and this service unit, which we hope to identify maybe in our change package, has offered to talk to everyone else about how they did it. So colorectal cancer screening, I think the challenges in colorectal cancer screening, which everybody on this call understands probably better than we do, but it actually has some of the same parameters where people are screened by the facility, but then they are sent out for follow-up and treatment, and those folks kind of get lost. They also have enormous challenges in terms of actually carrying through on follow-up. It involves significant transportation, sometimes an overnight stay. There's a service unit that has very much sort of, I wouldn't say conquered this problem, but is on their way to conquering this problem through intentional structuring of their relationships with their referral partners, and through accessing funding through the tribe to help support the components of this that cannot be supported by the service unit, such as transportation and housing, in order to get the treatment actually completed. So the occult blood kits are distributed by the clinicians, and they are prepaying postage. They send a reminder at both 2 weeks and 4 weeks. They pay an incentive. The tribe is financing incentives for returned kits. They have a pre-procedure visit with the service unit clinician, and then can access funding for transportation and hotel from the tribe in order for the folks that are referred to a distant place for follow-up with the gastroenterologist, that is now being paid for through tribal funds. So they now have the FOB return rate of 28%, up from, I don't know, somewhere under 5%. And their colonoscopy completion rate now is 47%. So that is, I think, better than many non-IHS facilities, certainly better than most rural facilities. We also saw a fantastic example of primary care and behavioral health integration, in which a service unit has developed quite an intensive program that has led to the actual hiring of a wellness specialist who is on site in the service unit, and who can be brought in almost as needed on ad hoc when, during the course of a non-behavioral health visit, behavioral health issues are identified by the regular treating clinician. So when in a primary care setting, you know, depression, sleep challenges, whatever is identified, this wellness specialist is on site and can be brought in to talk with the patient and identify whether or not they need formal behavioral health follow-up or need other sort of supportive interventions. So the problem is identified by the primary care physician, and they are the one that engage the wellness specialist. The wellness specialist then can recommend around referral to specialized behavioral health versus not, and can also self-schedule to follow up with the person by phone call or even by follow-up visits. They serve as the bridge to other community health services, and this has been extraordinarily successful. So next slide, I think I have it on the next slide. Not. Oh, so I don't have it on the next slide. So this was a really well-functioning program, in that I think a lot of times when additional personnel are brought in, there is sometimes resistance from the primary care clinician staff, but there is a huge amount of building evidence within this service unit that the primary care staff loves this, in that they can help, they can still sort of be, I'm not in charge of, but the aggregator of understanding sort of the holistic challenges to this patient, but they have a way to pass off to someone who has the time and the training to actually deal with the behavioral health components of, you know, chronic disease for sure, but of any given health visit in real time and in a way that is perfectly integrated with the other more sort of traditional care. There's a lot of different ways that health coaches are used. Certainly we saw, I would say, a best-in-class example of integrating health coaches into diabetes care. I think there's enormous interest in doing this, but I think we saw it done very, very well. Health coaches are care professionals in this service unit, and they are hired from the community, and I think it's a requirement that they speak the local language. They become trained in techniques of motivational interviews and with diabetes education training. Providers can refer patients to the coach through the electronic health record, or as in the previous example, they can just be brought in when a situation is identified during a routine visit. The coaches can do monitoring and surveillance function, meaning they can check in with folks between visits, and they are helpful in sort of risk stratifying within the electronic health record and within a dashboard for quality monitoring. Oh, whoops, we lost our. We didn't leave it everywhere. Okay. So the coach ensures that a patient-centered care plan is well developed and carried forward, and they are part of assisting in sort of the overall plan of care with regard to chronic disease management. It allows for a comprehensive approach to care, including spiritual care, and it builds and really ensures retention of the relationship between the provider and the patient. So next slide. So I know this has been a lot of examples. These are examples that we hope to have available in writing, actually within our change package, and then folks can really learn from these well written out examples. But I think the main thing that I took from all of these site visits, and I think our team has taken from the site visits, is there's actually a lot to celebrate that's going on in the IHS system. So I mean, it's enormously talented leadership and passionate and committed staff. And it's this notion of exceptional creativity with effective resource allocation and an actual movement towards population health models of care that I feel like put these service units into, like I say, this best-in-class category. And I'm not saying that just within the IHS system. I mean, I think we saw strengths here that are best in class no matter who is in the class. So I want to acknowledge that we learned a lot, and I think that you all have a lot to celebrate and to teach others. So thank you.
Thank you,
Becky.
both Jane and Brianna, for sharing about the implementation framework, as well as fitting those promising practices that we saw into that implementation framework, a way that is, which is the way we are trying to better understand all of the great work that is going on in these service units. I would like to take a minute. We will move on to a kind of a celebration and reflections piece as this is the final LAN, but I wanted to take a minute to see if anyone has any questions for our speakers for today on either the implementation framework or on the promising practices that we saw while in the field with you all. You are welcome to come off of mute and ask your question, or if you have a question, please feel free to chat it in. We'll take just a few minutes and see if anyone has any questions before moving on to our reflections piece. Okay, since I don't hear anyone joining in and I don't see anything in the chat just yet, I will, I'll move on to the reflections piece. Or I'm sorry, you know what, we have a few next steps that I wanted to share as well. We are still monitoring chat, so please feel free to enter any questions or thoughts you have for the speakers or anything else. I also included my email at the bottom of your screen in case you wanted to reach out to me directly about the implementation framework, the Quinn NCC, or those promising practices. So today's presentation was really our first shot at sharing what we've heard over the summer from those site visits. I think something we said all summer long was we are drinking from the fire hose. So we are still distilling out our lessons learned in a manner that we can share them back out. So this is our first venue for doing that. You guys are kind of our rough draft. So we appreciate your patience in learning about what we've learned about so far. What our next steps are for creating that change package of these promising practices is we will be convening a collaborative expert panel from experts in the field that can speak to many of these promising practices, strategies, innovations, or tools and resources that we heard about that we would like to disseminate to others. That panel will take place in early 2020. From there, we will receive feedback from experts to formally, to finalize that change package for dissemination. We hope also for we have the CMS Quality Conference taking place in February of 2020. We will be sharing that information out as we learn more. We hope those of you on the phone that want to participate in this conference, please contact your PATH PM or myself. This is really a great venue to share the great work, to highlight the great work that are going on in your service units. And I am more than happy to work with any of you who would like to either just attend the conference or speak at a session about your work, please reach out to me. After these events, we will have that change package finalized and disseminated. We will have more updates on that product and its release close in 2020. So thank you everyone for your time today. Please reach out with any thoughts or questions for me. And as this is our final LAN, I wanted to take a minute to reflect on all of the great work. I would like to actually start with Demetrius, the director of PATH, to share some thoughts and reflections during this final LAN. So Demetrius, if you could come off of mute and share some of your thoughts with us.
Thanks, Becky. So I was thinking about this, and one of the things that I was really proud of is the strong relationships that the PATH project managers have developed with the service unit leaders and the quality managers. These IHS staffers are trying to achieve better healthcare for Indigenous Americans in remote and underfunded environments, and they are still making time to sit down with PATH folks and commit time and resources to building quality capacity at their facilities. And then something that I think is that we've learned and that we continue to implement or want to share with others, that to harness the passion of IHS staffers to create a better healthcare system, we must first take the time to listen to their perspective of the situation before us, and then honor what was heard in the next steps. It has to be a collaboration. It has to be a partnership where there is space and consideration for what everyone brings to the table, because expertise is useless without the lens of lived experience. And then I think the most powerful thing that I've learned personally from the collaboration is that the strength of this project is the collaboration, allowing space for diverse thought and points of view. The PATH IHS and Quality Improvement Organization partners in this project had a culture of transparency and sharing that allowed the brightest and most innovative ideas to move to the front and to be shared. These many different perspectives could have just as easily resulted in project chaos and conflict, but the stakeholders are also very committed to these shared goals of wellness for our Indigenous countrymen, that the differences became our strength and not our weakness. So those are just some parting thoughts I had. Thanks, Becky.
Thank you, Demetrius. I believe we have Stephanie Glenn from CMS on the line. Would you like to share any thoughts with us? Stephanie, if you are on mute, we are not able to hear you.
Can you hear me now?
Yes, thank you.
Okay, my apologies. So I've been on this project now for a little over a year, and I'm really sad that it's coming to an end. You know, I echo everything that Demetrius said, you know, but we've formed such a nice collaboration, and I can't say enough how amazing that is. Keep the momentum. You know, that's my charge to you, you know, as this program is coming to a close. Keep the momentum, you know, keep communicating with each other, and keep looking for new ways to network, you know, perhaps with other service units or clinics that you're not in touch with now. Reach out to them. You know, you all have more in common than not. And every one of you has a unique pearl of wisdom to share. So, you know, I want to thank everybody for all their contributions, you know, throughout the entire length of the program. We've been proud to be a part of this. We're proud of the progress. And again, just keep the forward momentum going. And I'll end there. Thank you.
Great, thank you, Stephanie. Thank you for joining your thoughts or sharing your thoughts. I was curious if we had anyone from IHS headquarters on the line that would like to share a few reflections. and you may still be on mute. Well, I'd like to open the line for anyone else that might want to share any lasting thoughts for your work in this collaboration, to respond to any of these questions, or if you just had something you would like to share in these last few minutes of our final LAN. And you are more than welcome to chat them in. I am happy to read them out. Okay, wonderful. If you do have any thoughts, please feel free to chat them in or to send me an email. In our last 2 minutes of this final LAN, I wanted to make sure that you all, if I can get the screen to advance, are aware of there will be a final think tank in December. Francesca, I didn't know if you wanted to say anything, or Demetrius, about this office hours that will be hosted next month.
Yeah, so just as a reminder, we have an open office hours in December talking about AIM3 sustainability. If you have the time and you have any questions, please feel free to drop in and hear from some of our leads on AIM3 and some of our analysts, and we hope to see you all there.
Great, thank you, Francesca. And I see a few more items are rolling into chat. This is what we had for today for your final LAN. We appreciate everyone joining us, learning a little bit about what we've learned from you, and we're excited to share what our next steps are and what that change package will look like. I also look forward to seeing a few of you for the collaborative expert panel, as well as hopefully at the quality conference. So I will type my email into chat for all of you, and please reach out if you have any questions or comments for me. And I hope you all enjoy the rest of your day. Thank you so much for joining us today.